Hello, good morning. So I'd actually like to start with a little bit of recognition. I want to first thank the Behavioral Health Division team for assisting in pulling off today's event, and also to Superintendent Baszler for her comments earlier. I really feel grateful for the opportunity today to have this conversation about behavioral health and education. Most of the time when we're talking, we speak in human services, we speak in education, we speak in health. And all of those items and those systems are so integrated, so this is really a rare opportunity for us. I also would like to recognize the legislators that are here today. So if you're in the audience and you're a legislator, could you just stand up? And then could we give them a round of applause, because they've done amazing work this year. Thank you. And thank you for being here today. I keep saying that the next 12 months in behavioral health are going to be the most pivotal months that we're going to have. We are truly transforming a system in a way that we haven't before in North Dakota. We will have services we've never had before. We're changing policy. We're changing even the way that we treat behavioral health. And one of those examples is that often in North Dakota, we see behavioral health treated like a social service or a grant. It's something where we write grants in order to have funding to pay for services. But behavioral health is health, and it really should be treated that way. And if we're going to treat behavioral health as the condition that it is, then payers, providers, and those of us who work every day with children and families, we need to have the same services available. And behavioral health should be treated on an equal footing as the rest of health. I also would like to, thank you. I also would like the opportunity to thank First Lady Catherine, who's here today. She has been an advocate not just for addiction, but for behavioral health and for the efforts that we have in the state. So thank you, Catherine. Thank you for all of your work. And thank you for being here today. I know that a lot of our work in Recovery Reinvented and the efforts have focused on adults and systems, but we're here today to talk about children, to talk about families, and to talk about how we can partner. So thank you for having me here today, and I'm hoping that today I can provide more information, not just about what is behavioral health, but what's happening in North Dakota's behavioral health system. What are we doing? What are the changes? And what can you look forward to in the next 12 months? So one of the first things I want to do is make sure that we're using the same terminology. Many of you are used to hearing the last few years in North Dakota, behavioral health. It's so important, and everybody's focusing on behavioral health needs and the behavioral health crisis. But often you hear people say things like behavioral health and mental health, or behavioral health and addiction. And one of the things that's important to recognize is behavioral health is really an umbrella term. It's a term we use when we're speaking about wellness, prevention, things like depression, anxiety, and often it's preventative. So things in the realm of public health, resiliency, and focusing on risk and protective factors. So today, when we use the word behavioral health, we're really using it as a global term so that we're all talking about the same thing. I'll be talking a little bit more about the different realms of behavioral health and how we can focus on it. But one of the first questions I get when I say, I'm the Behavioral Health Division Director for North Dakota, people say, why does everybody care so much about behavioral health right now? Why is that important? And I just want to draw your attention to the fact that we know that individuals with behavioral health disorders die on average about 5 years earlier than persons without these disorders. And if we look at individuals who actually have this serious and chronic mental illness, they are now dying 25 years earlier than the general population. We would not accept this in the world of a health condition. We would not say, well, that's okay. What are we going to do, and how do we get behavioral health, again, to be treated on an equal footing as the rest of healthcare? So just to kind of set the stage, I want to talk a little bit through North Dakota's data. On average, 4% of North Dakota's population, and this is the adult population, at any point in time has a serious mental illness. What that means is a chronic condition that they will more than likely manage and find recovery throughout their lifespan. At any given time, 13% of the population may be dealing with a more acute mental illness, anxiety, depression, grief, dealing with an illness and a co-occurring disorder, having an addiction. and being able to potentially find recovery. Then lastly, 83% at any point in time have no specific mental health condition. I want to talk a little bit about substance abuse also, just to set the stage. So when we look at North Dakota data compared to national, one place where we consistently have data that's higher than the national average is binge drinking. And I think everyone's familiar with that. We hear media stories like we're the beer belly of America, or our cities are voted the city that has the highest binge drinking. And sometimes we wear it as a badge of honor, it almost seems like, in our culture. Binge drinking is one of the highest issues that we deal with in the state when we look at the contribution to social issues. Car crashes, the correlation with domestic violence, and the things we deal with every day. When we look at our rates for other substances like marijuana and illicit drugs, our rates are lower, and that includes opioids. I also want to talk a little bit about North Dakota data. Superintendent Baszler earlier talked about the Youth Risk Behavior Survey, but one of the things I want to really focus on is what we have been seeing in the trends. So starting in 1999, this is the data from the Youth Risk Behavior Survey specific to students reporting feeling sad or hopeless. And you saw we were making progress up until 2007. And starting in 2007, we start to see an increase. We're seeing more students reporting that feeling. And that also correlates to what we see when we started asking the questions around student suicide. This graph starts at 2007, where we see those increases. Seriously considered attempting suicide, making a plan. These numbers are increasing. Often I get asked, well, why? Some people believe it has to do with technology, the access to having one of those mini computers in your pocket, right? Having someone that can constantly be communicating with you, whether that's in a way of bullying or whether that's in a way of comparing yourself to others and seeing other people's lives through the lens of social media. But I think it's really important to acknowledge that in North Dakota, we are seeing a significant suicide issue, and we need to address it. One thing that changed this year during the legislative session is that the suicide program was historically in the Department of Health. And so we had requested in the governor's executive budget request that program really needs to be merged into behavioral health so that we can look at suicide and preventing suicide across our full continuum. So that's one of the changes that you're going to hear about today. But I want to talk about some of the positive data, because so often we focus on what the negative is. But in North Dakota, when we look at underage drinking rates, we have actually cut our number in half. Our underage drinking rates in 1999, this is current alcohol use in the past 30 days, we have gone from 60.5% to 29.1%, making incredible progress, right? So why did that happen? I can tell you we have spent more than the last decade with funding and resources and opportunities to try to address underage drinking in the state. We don't have a lot of resource, but where we do have resource, it's been very purposeful. And so we have implemented strategies in communities with local public health agencies and in partnership with tribes. Here's another point. This is taking the youth risk behavior data and looking a little bit deeper. So this actually compares now 4 different years of the data. And if you look at the first column, this is the most important. Lifetime alcohol use. Not only do we see a decrease in past 30-day use, we see more students choosing to not drink at all. This is lifetime use. So we have seen consistent increases in 0 days of alcohol use. And at the same time, if you go to the very far end, the reason this question is so important is, are students binge drinking? Are they experimenting? Or is this something where we have a chronic issue that we need to be addressing in a treatment way? And if you look on the far end, you can see we are also making progress in the realm of seeing decreasing of consistent daily use and those types of patterns also. I also want to talk a little bit about underage drinking and the impact that that has for future addiction. So we know that individuals who start drinking before the age of 15 are 4 times more likely to have an alcohol use disorder than those that begin after the age of 21. When we did this survey back in 2003, 25.4% of the respondents said they had their first drink prior to that age. Today, that's 14%. So if we can continue to decrease that first or that age of initiation of alcohol use, We can make progress in the long-term problem that we're dealing with in access to services and treatment. And that's why prevention is so important, because every dollar that we invest in prevention saves dollars ultimately in treatment. I also want to point one more thing out. In North Dakota, and I'm born and raised North Dakota, from a small town, culture is so important in who we are. We work hard, our lives are based on our values. One of the things I want to point out is that we have a perception that doesn't always align to reality. So when you look at this survey, this was a survey that we conducted of adults between the ages of 18 and 26 who are not in college, so not focusing on the university population. And we said, how many of your peers are binge drinking? And if you look at the very bottom bar, so 59% of young adults did not binge drink in the past 30 days, but only 1% of their peers believe that to be the case. Why is that important? Because everything we do in communication and messaging is around that. It's culture. Do we actually create the perception that everyone is doing something or that this is what's happening? So it's so important to understand the reality of what we're dealing with versus the perception. I also wanted to make everyone aware that we have a website. It's called sund.nd.gov. It stands for Substance Use North Dakota. This is a data website where you can go in and search regional data based on substances, based on demographics like age, and you can actually go in and search for information that could be helpful in writing grants, if you're looking at your own area, or also looking at the trends in some of the data I've presented today. We also have data booklets available at our booth out in the lobby if you have a minute and want to pick one of those up. So now to talk a little bit about the roadmap, the transformation that we're achieving right now in the behavioral health system. So I want to give a little bit of background. So really starting in 2014, and for those of you in the behavioral health system, you know that this is really kind of the awareness stage, where we, for the first time, were saying North Dakota's behavioral health system is in crisis. And that's what the Schulte report told us. There was a study done, a legislative interim study, and it said, North Dakota is not meeting the needs for the people who have behavioral health conditions in the state. We are in a state of crisis. And in 2016, we added on that by doing further assessment. What are the gaps? And what are the recommendations? And what are the resources? What do we already have? But neither of those got to the numbers, right? And if we want to make change in our state, and if we want to be able to know how we can go in and ask a legislator to advocate for something to be different, we need to be able to have data to talk to that. So in 2017, we commissioned a study from the Human Services Research Institute, which ultimately became known as the HSRI report. And that report, for the first time, pulled data from expenditures at the Human Service Centers and Medicaid. Now, for those of you that don't really love talking about numbers, that might not seem that exciting, but it's a really important thing when we talk about the change that we're making in our system. So I want to point out this data. When you look at the money that we're spending right now in substance use disorder treatment, and this number does not include the North Dakota State Hospital, okay? Of the $19 million expended, more than 85% of that was in the highest level of care. That means residential or inpatient treatment. Why does that matter? Well, number one, every time someone has to leave their home community to get treatment, we have dissolved natural supports. We have potentially had children placed out of home. Someone has a really difficult time maintaining their apartment or their housing and their job when they're not even at home. But our treatment services don't necessarily meet that need. If you live in Williston and you have to go to Fargo to get the residential care you need, you are disrupting those natural supports. So what if we took even just 5% of the money that we're spending on that highest level of care and reinvested that in community services at home, so that someone could get the supports in their home and in their community instead of going somewhere? And I'm going to be honest, when I go out and meet with communities, when I meet with schools, when I meet with stakeholders, when someone is identified as having an addiction or a mental illness, the first thing people say is, where can we put them? That's our first instinct. We go to bricks and mortar. Where can we put someone? Where can they go? And our first instinct should actually be, how can we support someone? How can we keep families together? How can we get the services there? And that is really vital because we have had such a lack of resources and services that we don't even know to think of that first. So that's a big part of the strategy that headed into this legislative session. I want to show you the same graph looking at the $59 million that we expended in mental health services. $59 million, not counting the state hospital. Residential, inpatient, and long-term care facilities accounted for the majority of our expenditures. So again, we have to think about our return on investment. When someone goes to an inpatient facility because they have an addiction, and that's the first line of thinking, we are doing the same thing that healthcare would do by treating everyone in the emergency department. We don't intervene, we don't have primary care, we don't have those urgent care, right? Like if we're not using all of those different levels of services, we're treating everyone in the emergency room. Return on investment is key, because even if you're lucky enough to get access to one of those beds or one of those residential facilities, what do you do when you return home? How many of our communities have robust community-based services to support someone after they've had the acute treatment that they need? That's the return on investment, recovery support services. So whenever we can, we should prevent. Whenever we have an opportunity for an early intervention, we shouldn't miss it. Treatment is essential for people who need treatment. And if someone has a need for recovery support services, that must be ongoing. It's not an acute time frame. It's a chronic illness. I also wanted to point out a couple other pieces of data. A high proportion of the foster care children and youth admitted in 2016 and 17, looking at, for example, foster care, therapeutic foster care. Of those numbers, look at these percentages. They had adverse childhood events, and you're going to hear about that later from Dr. Herding. But 52% had an incarcerated family member. 77% had a caregiver with substance abuse. 83% had experienced caregiver abandonment. Imagine trying to do education with all of these things that we're dealing with just in basic need. Basic safety. I also want to point this out. 42% of the children removed from their homes in North Dakota were because of parental substance abuse. 42%. That's a number I want to change. Because my question is, were they removed because they had a parent who was not able to access services? And what damage do we do when we disrupt a family because of a lack of resources? 42%. And we can change that. And that's really what I'm here to say today. How do we take all of this data and this information and make informed and strategic decisions so we can reform the system? In the study we did, it was a 250-page report, 65 key recommendations broken into 13 categories. I've highlighted the 4 here for you today. There are 4 that are absolutely vital when we talk about education and behavioral health. That we as a state need to, number 1, invest in prevention and early intervention. It's cost effective and it's the right thing to do. Number 2, to ensure that North Dakotans have timely access to behavioral health services. If any of you have had a child in a behavioral health crisis as a family member, and you call to get a service and you're told, come in 2 weeks, what do you do for the 2 weeks in between? What do you have available? Those are the things that we need to look at improving. Next, how do we expand outpatient and community-based services and have a full array of services so we're bringing services to people where they are? Whether that's in schools or in homes, in the jail, in emergency departments. How does our behavioral health system start to connect to the rest of the sectors, right? Schools, public health. And lastly, how can we enhance and streamline our system of care for children and youth? Right now, they are completely separate systems. And every single day, someone brings something forward and they said, hey, you know what? I really wanted to get that service, but the only way I can get it paid for is if I have a child who is under the care and custody of the county. So now we're incentivizing a child or a child abuse and neglect report in order to get a service that should have been an early intervention. Those are the systemic changes we need to make. So, this study was very pivotal in developing how we move ahead to transform the system. But I also want to drive home that these are very, very real situations, and many of you that work with children have examples just like this. But I want you to meet Jessica. Jessica is 11 years old. She was diagnosed with ADHD and has a history of self-injurious behavior. She has behavioral health issues in school that resulted in several referrals to the school resource officer, which eventually led to a juvenile court referral. A year ago, she successfully completed residential treatment. However, the recent loss of her grandmother led to some suicidal ideation and an emergency department visit. The residential program that she successfully completed said they will not take Jessica back because she's maximized benefit from the program. And a program out of state will take Jessica, but only if she's referred from social services and on North Dakota Medicaid. Where does Jessica stay right now? How about 2 days in an emergency department before she's transported to another state with none of her natural supports? This happens every day in North Dakota, and this is the reason we have to change. So how do we change? How do we turn all of that knowledge and everything that we have into progress and something we can all be proud of? 3 key things. We have to support the full continuum. We cannot steal prevention funding to pay for treatment. We can't say we're not going to have recovery support services because we decided to invest in prevention instead. We need to increase community-based services so that people can get services that they need in their homes, and we're not actually creating more trauma by not doing that. And lastly, we need to stop using the criminal justice system as a behavioral health system, because it's not. And when you have to go to prison in order to access a service, that is a broken system. And we have many examples in North Dakota where we can do better. And one of the first things when I think about children with that is as a parent. So if it's 10 o'clock at night and you have a 10-year-old and you're struggling with knowing what to do and how to intervene, you're forced with 2 options. Do you call the cops and potentially tell on your child and start the path into the juvenile court system and referrals and engagement with law enforcement? Or do you call social services and tell on yourself? Because those right now are the 2 ways to get the majority of the community-based services in our state. So I want to talk about that continuum of care. First, promotion and prevention. This is where we actually try to prevent something before the onset. How can we build healthy and safe communities? How do we build children who are resilient? Because very few of you in here have probably not had absolutely devastating life events that changed the course of your life. But you're here today because you had a level of resiliency to find a way to bounce back and to persevere. And that's something we have to be able to teach. We also need to look at that investment of healthy communities and protective factors. We right now can identify, just knowing, who are going to be the youth that are most likely to develop a future addiction or a mental illness, and not just sprinkle resources on everyone. How do we target our resources so we're actually identifying those at highest risk? Parents Lead is a program that I hope that you're all aware of. But Parents Lead is a program that recognizes that parents are the #1 influence in their children's lives. And one thing that we currently see is that we go to a meeting and it's just about children. And if I bring up adults, this is what I hear. Oh, we're just here to talk about kids. I've run addiction treatment programs where kids come and live with us in a residential facility, but guess what always happens? They go home. So to not have services available for families and for parents, we're missing that opportunity to engage with parents. And sometimes the parents we're most trying to engage with are the ones who are least interested in engaging. So Parents Lead offers resources for recognizing symptoms in the classroom, tools for social workers that work every day with some of our highest risk families. And we have resources available in the lobby. I hope you took a chance to look at the cards on the table, and those are some of the conversation starters that we have to start some of the conversations between parents and children. I also want to talk about early intervention. This is the system in North Dakota that is almost absent in the realm of global behavioral health. So I have been the counselor who did an assessment and said, "I'm sorry your kid's not bad enough yet." Feels awful, but I have to say it. I've actually looked parents in the eye and said, "I'm sorry your kid's not bad enough yet." Why? Because there's no reimbursement for early intervention. So we weren't allowed to do that where I practiced. So we wait for someone to get worse. And then we use the emergency room in order to treat those conditions. So I wanted you to think about a couple of things with early intervention. We know who's at highest risk, and if we were to implement strategies, we can change that trajectory for that child. Half of all of the people with mental and/or substance use disorders are diagnosed by age 14. 3/4 of people with these same conditions are diagnosed by age 24. So where can we invest our resources? I also want to show you this slide. This shows the window of opportunity that we're missing. The point in time between the first symptom and a diagnosis. How much time are we missing between symptom and diagnosis? And why is that important? Because our systems are based on reimbursement. So we say, well, until there's a diagnosis, we don't treat. But what are we doing for early intervention? How are we taking the opportunity of that window? If we intervene at that point in time, we can prevent the disorder from developing. We can reduce the consequences. If it's something we can't prevent, we can get the right services to the right people at the right time. Treatment. I think a lot of people are familiar with the clinical services available in treatment. But in North Dakota, we actually have limited treatment services. We don't have the capacity to meet need, not just in rural areas. People talk about the gaps in the rural areas. We have a lack of services in our urban areas. We globally have a lack of connection and resources for community-based services. Lastly, recovery. When we talk about recovery, this is the second area that's a very large gap in our system. We're making progress, and I'm excited to say that we so far have trained more than 250 peer support specialists in the state of North Dakota, and the majority of those peer support specialists actually live in rural areas, not in the urban areas. Why is that important? Because sometimes having one other person who's experienced what you've experienced is more beneficial than knowing someone who's a therapist, or having someone to be able to call at 2 o'clock in the morning when you're struggling. And for any of you that have had a child born with a disability, I'm just willing to guess that maybe one of your first thoughts was, how do I find another parent who's experienced this so that I can know what to expect and how to navigate that system? Those are some of the things we can offer in recovery. And this is really the summary of all of what I've just said. How do we ensure the availability and access to a broad, flexible array of effective community-based services and supports for children and families in order to address their needs? This is it. This is what we need to do. And if we can work hard at finding a way to say yes instead of finding a way to say no, we can change this. Right now, we almost find ways to say what can't happen instead of finding ways to say what we can do. And that's our opportunity. Behavioral health is health. And if behavioral health is health, reimbursement should exist for those same conditions. Classroom teachers are not expected to treat diabetes. Are you equipped to treat mental illness? Are you equipped to treat addiction? Why is that different? Why don't we treat that the same way? So let's talk about that, the behavioral health system and the education system. So I'm going to be honest, I'm a little bit nervous to even be here today talking about this because I'm afraid I'm going to use the wrong words and I'm going to say the wrong thing. And I don't know the education system, and I'm not making assumptions about what is or isn't happening in the education system. I'm just Pam from behavioral health, and I can only speak to what I know from the behavioral health world. And 2 years ago, everyone kept coming to us and saying, behavioral health is a crisis in the schools, what are we going to do? And we had to really sit down and figure out, what are we saying? We're not even using the same words. And that's where we started a few years ago. Just in the last 2 years, really meeting with representatives of administrators, Department of Public Instruction, Department of Human Services. We sat down and we said, what are we all even trying to achieve, and is it a shared goal? This is the first thing we came to. We were using completely different words. We actually were talking about the same thing, had no idea we were talking about the same thing. Sometimes we were talking about completely different things and thinking we were talking about the same thing. And sometimes we were offending each other, not knowing we were offending each other until the next meeting we'd be like, hey, you offended me. Which I'm grateful that people would say that. But I want to give you an example of this. This is a personal example for me. But I've been a mother who received a phone call from an emotional disturbance specialist. And I have to tell you, I had a moment where I was like, what the hell is that? Because I didn't know. I don't know what emotional disturbance specialist is, and I'm the director of the Behavioral Health Division for the state of North Dakota. And some of you in the education system can be like, what? How would she not know that? It doesn't exist in our system. It's not a thing. The thing I'm grateful for today, though, is that there is an emotional disturbance specialist who calls herself my son's school mom. And she fights every day for him. And I'm grateful for that. But I don't even know what that is. And then I think, with all of the resources and all of the abilities and all of the things I have at my fingertips, and we're not talking the same language, how do other parents do this? They don't even know necessarily the questions to ask. We're not connecting. So we made it a mission 2 years ago to say, how do we start saying the same thing? How do we have a shared goal and a shared mission? One example, just to give you, MTSS means absolutely nothing to the majority of behavioral health professionals. I was like, what's that? You know, because we always make our acronyms like fun so we can say them. I didn't know what it was. But if you just saw what I walked through in the continuum of care, it might have felt a little familiar, right? Is it the tears? When we can prevent and do something in a global way, we do that. And then we identify the kids that are higher risk. And then we actually identify those kids that need some type of intervention, right? It's connecting, right? We don't use the same words, we have the same things. We just don't say it the same. So we started working on that. The second conversation was a conversation I actually was very nervous to have, because I didn't want to offend anyone, but I had to ask tough questions. And I was afraid that when I said, hey, behavioral health isn't special ed, you guys get that, right? I was nervous. Because most of the time when I'm hearing people talk, even in legislative hearings or at stakeholder meetings, when people talk about behavioral health issues, they completely connect it to special education. And the more that I met with people from special education, they're like, oh, thank you for saying it. We don't know how to solve behavioral health. That's not actually what we do. Is there overlap? Yeah. Is there connection? Sure. But it's not the same thing. And I think it's really important to recognize that, because often the barriers to reimbursement for service actually comes from us saying, we're not going to pay for that unless a child's on an IEP. Because somehow that IEP then makes it be medically necessary. But an IEP is not an easy thing to achieve just because you have a behavioral health condition, right? There's a really important thing that you need to have in order to qualify for an IEP. What is that? It has to be affecting academic progress, right? Whether that's academic failure or whatever word you want to use, okay? So you can have a child who has a desperate need for a behavioral health intervention who will never qualify for an IEP. And why? Because school might be their safe place. School may be the one place where they achieve, and you guys know this, you say it. But yet when we develop systems and we look at things, we don't say that same thing. So children with a behavioral health need are not necessarily going to qualify for an IEP. Two different things. Is there overlap? Absolutely. But not completely. We have children with those silent symptoms. I also would challenge you to say, how do we measure success in those two systems? As a mother who goes to IEP meetings, I know one way that we measure success. Academic performance, right? There's these amazing strategies and tools that have been utilized with my son that have created the ability of him to actually make incredible progress to the point where we say, does he really need an IEP? And I'm eternally grateful for that and for the people who've brought that forward. But for a child who actually needs healing and recovery, we measure something very different. They're not the same goals. So the other thing I want to talk about is identifying children as just being naughty, because I hear this a lot when I go out too. We sometimes just have naughty kids. They're the ones that come late to school, they don't care, and they're doing it on purpose because they're making that choice. Behavior used to be attributed to poor choices, not behavioral health globally like we talk about it today. But I want to challenge you to think about one thing. We're going to talk later about MTSS and have more discussion about that and changing culture within schools. But I know personally that sometimes there's a kid who's tardy for school because his mom couldn't get out of bed. And he got his siblings ready to go to their schools, and he's late. And when we meet him at the door, we should say, are you okay? Do you need something? Instead of, why are you late? And you're going to be punished for that. Because sometimes they're just holding it together. And it's actually a family problem, or potentially theirs. But the part I want to challenge you to think about with that is, who do you have right now in your school system that is qualified to decide which kid is naughty because they're choosing to be naughty? Which child has that naughty behavior because it is a symptom of their behavioral health disorder? Or, as you just heard Dr. Ablon say, because they lack the skill? Who gets to decide that in your school? Do you have people that do that? Are they credentialed to do that? Do they know the difference between a symptom and a choice? That's the question we have to ask ourselves, because we right now have a naughty box where we put kids. They're naughty. And I hear it. This also leads us to the question we need to ask ourselves about our different credentialing processes and our separate systems. I didn't know what an emotional disturbance specialist is because it's not actually identified within the behavioral health credentialing. It doesn't exist in the realm of behavioral health and reimbursement. I don't know what it is. We have two separate systems. So many schools right now are hiring a behavioral health professional and saying, we need to hire a social worker, and that social worker can fix some of these behavioral problems. So they hire a social worker, and they expect that one individual to be able to solve the problems of the behavioral health issues in the school. And guess what? A large percentage of the time I'm finding they've actually hired someone who can't do what it is that they needed, because they didn't know that there's a difference in the type of social worker you hire. There is different scope of practice. There are clinical social workers who develop plans, and there's other social workers that have different scopes of service to that. That's something that when I meet with schools, they often don't know. So do you have someone who can do those services? That also leads to reimbursement. Very few clinical services are not reimbursable. But if you hire the wrong person, you cannot bill for that service. And imagine if we could transition from a grant-based social service charity system in behavioral health to a healthcare system. We could take those grants and do things that would go well beyond just those clinical interventions. Next, now we get to the what's happening. I've covered a lot of topics so far, but this is the one I'm most excited about. I mentioned earlier that this is the most important next 12 months in North Dakota's behavioral health system. It truly is. We have made changes in a way that I never really thought were possible, and I am so grateful for the leadership from the executive branch, from the governor, First Lady Catherine, Chris Jones, and all of the rest of the cabinet. We work closely with other departments. But I'm really proud of the work the legislators did this session. And I'm really surprised that nobody's talking about it, and nobody's like screaming it from the rooftop. Because we usually head into a legislative session expecting two things. Number one, how can we just make sure we don't get cut? let's make sure we walk out not less than what we came in with. And number two, maybe there's one thing we'll actually get. And we've headed into every single legislative session with that. And I have to tell you, this year was completely different. Every single item in the executive budget request passed in some way, shape, or form. Every single item. That doesn't mean tons of new money. Sometimes it means policy change that removes the things where we incentivize kids to be placed out of their homes. Sometimes it means connecting and collaborating in a way that might be more meaningful. So I want to go through a few of those items. Some of you may not be aware, but we actually have a substance use disorder voucher in North Dakota. This is a very special thing. This was our one thing we walked away with 2 sessions ago that we were so proud of. Right now, there are things that if you are on Medicaid don't get covered. There's just non-allowable expenses. So the voucher is general fund or state funding that ensures that individuals can go to, number one, a private provider to get that service. They don't have to go on a waiting list for a public sector, right? They don't have to wait or not have choice of their provider, so they can see their provider in their hometown. And the provider gets brought a little bit closer to whole because we're able to reimburse services. So up until this session, this has only been allowed for individuals over the age of 18. We are right now drafting administrative rules to bring this down to age 14. In North Dakota right now, if a child or an adolescent has an opioid use disorder, methadone's not reimbursed by Medicaid. So the best practice medication, the thing that actually is the effective strategy, is not actually reimbursed. The voucher pays it. So this is really important when we look at addiction and the transformation there. Number two, we actually saw the legislature invest for the first time not just in substance abuse prevention, but mental illness prevention and mental health promotion. We have funding to begin looking at that. And that's the reason I bring up the YRBS data. In order for us to be able to really tell the story of what we need, you can see that we have made progress in the realm of substance abuse that we haven't made in the realm of mental health. This will be the first time we're investing in that way. We also had the transfer of the suicide program into the behavioral health division, so we can much more closely integrate those services and think about suicide prevention from the earliest level of prevention to supporting families. And ensuring that if someone is referred, that there's a clinical intervention that's a best practice and can be utilized. We also, for the first time, are going to have certified peer support specialists. That means we are professionalizing, as part of our workforce, individuals with lived experience so that they can build a career helping others. That we don't expect people to just volunteer or do the best they can to meet someone's need, and this is vital for expanding in the rural areas. This peer support certification is not just certification, it is also being added to the Medicaid state plan. So peer support will be a reimbursable service for the individuals who are certified. I also want to note that we're going to be able to continue the school behavioral health pilot we're working on with Simley Middle School in Bismarck. You're going to hear more about that today. We've also removed some barriers around targeted case management. Up until now, targeted case management was only reimbursable to the public sector and tribes. Private providers can now bill for that service. And lastly, the 1915I. The 1915I, it's not a very attractive name. It's a state plan amendment, but what does it mean? Starting July 1st of 2020, so less than a year from today, children with an addiction, a mental illness, and/or a brain injury will have access to reimbursement for services that never existed before. Never existed before. And for some of you that know what that's about, it's a really, really big deal. That means that we will have the opportunity to create providers and services and this entire system that doesn't exist today, so that we can reimburse supported education, respite, peer support services, parent-to-parent, in-home therapy, all of the things that right now you don't get if you have one of these conditions. We also saw from Senator Davison brought a bill forward that is a behavioral health grant program for schools. $1.5 million in that grant program is to launch also July 1st of 2020. So that's another opportunity that we have to address the behavioral health needs. And I want to point out one thing that will change Right now, there's just a lack of service, but when the Medicaid plan changes happen, we're actually going to find that some of the people who will get the least service are those that are insured, but don't have that coverage for those services that are those home and community-based services. So it will change where we're seeing gaps in our system. We also receive funding to expand what's called the Free Through Recovery program. The Free Through Recovery program was a partnership that we had with the Department of Corrections and Rehabilitation, and it created care coordination and peer support services for individuals in the community. And it's outcome-based. So we reimburse based on achievement of goals, recovery, and making progress, housing, employment, stability, things like that. We are going to now be able to expand that program to families. We are working with county social service agencies to really develop that program, and we're hoping to be able to launch midwinter. That's going to provide supports for families to bring down that number we talked about earlier, that 42%. That 42% of kids that get placed out of home because of parental substance abuse. If parents had access to those services, and it's not just substance abuse, it's also mental health. Hopefully, we can keep families together. And lastly, Senate Bill 2313 started to make some pretty significant changes in the children's behavioral health system and the children's system globally. One thing is that the Department of Human Services has been directed to develop a system of services and supports. What that means is the example I gave earlier about if it's 10 o'clock at night and you're a parent of a 10-year-old and you don't want to tell on yourself or your child, how do you access services? That's one of the things we've been tasked with developing. How do we have a system that can address that? Second, it established a children's cabinet across all branches of government so that the governor, the chief justice, and so legislators will come together and say, how do we really look at children's services across all systems and remove those barriers? Lastly, it established a commission on juvenile justice. Juvenile justice laws have not been updated for decades in some cases. And so the opportunity we have to look at how we can make changes from a punitive response to a therapeutic response is a huge opportunity. This is the last thing that's about this bill, 2313. There were two bills that addressed what's called behavioral health resource coordinators. And the first one says the Department of Public Instruction must keep a list of school behavioral health resource coordinators in every school, but the Department of Human Services is responsible to provide resources, to get information and connection to services to those behavioral health resource coordinators, so that we can start developing the relationships and the partnerships and the access to services that we don't have today. Lastly, I just want to talk a little bit about opioids. So North Dakota was the second to last state to get opioid treatment programs, and we hear a lot about the opioid crisis. We do still lose more individuals in North Dakota to alcohol than we do to opioids. But the opioid crisis is important too. One of the things we did this session is create the opportunity to have opioid treatment programs have medication units. How does this affect you? Right now in North Dakota, there are families that live in Grand Forks or Dickinson that have a parent that needs to get their daily medication, and we only have 3 locations in the state: Minot, Bismarck, and Fargo. So every morning at 6 o'clock in the morning, families load up in the car, they drive to Fargo, they get their daily dose of medication, and they drive back home in order to go to school and work. This will remove that need for that individual to drive every day to access those services. And so that's great progress when we look at getting services closer to home. Lastly, I just want to thank you for the opportunity for me to be here today and to speak with all of you. I'm excited about the opportunities we have with Dr. Ablon and working further to change some of the things that right now are those barriers in our systems more closely working together. So, thank you.